Thank you for the invitation to talk about bipolar disorder. The title for this evening is Bipolar Disorder, Relapse Prevention. And the focus of the lecture will be on understanding what bipolar is and then talking about different techniques around relapse prevention. But it's worthwhile understanding the core aspect of the condition because it's only when you bear that in mind that a lot of the signs and symptoms associated with the condition begin to make sense. Bipolar disorder, in essence, is a disorder of the psychomotor function in the brain. We all think at a certain rate. If you never had any significant mood disturbance, you'll say, well, mine has always been the same, it's never changed. And you may be actually quite unaware of the fact that it can change. But for people who get very depressed, it slows up. For people who get high, it speeds up. And you can actually trace all of the symptoms then from that core function within the brain. And in a sense, it's reasonable to think of it like a spinning wheel. When somebody is depressed, this wheel slows down. Now, by the way, for anyone that thinks that there is a wheel there, it doesn't show up on MRI, okay? But it's there all the same, and it churns off thoughts. And those thoughts that it churns off are projected into the future. However, when somebody is depressed, as in this slide, that does not happen. So when the person is trying to project their thoughts into the future, it doesn't really quite get to the visual display unit in the person's mind. So when you ask somebody who's severely depressed, how do they see the future? They'd say it's bleak, it's blank, or there's nothing there. So that's basically what's happening. The person is looking at the visual display unit in their mind and there's nothing there. So what is characteristic of what happens in depression is the wheel is rotating more slowly. And because it's rotating slowly, two things happen. One is it's less into the future and it's more into the past. And when it goes into the past, the thinking is actually negative. Now, normally we look at the past in a positive light. We talk about the good old days when people were more polite, things cost less, there's less traffic on the road, and so on and so forth. That's just a part of the normal human rose-tinted view of the world. But when people get depressed, that immediately turns to a negative perspective, and the person maybe has images in their mind of traumatic experiences in childhood, and they stick with the person. The next aspect of an introverted or a slowed down thinking process is the person's mind becomes naturally introverted. Normally we think outside into the future. We're inclined to connect with the world. But when depression strikes in this way, a person's thinking becomes introverted. Introverted in two senses. One is that the person becomes self-conscious, self-aware. And that may be the person's presenting symptom when they get depressed. The other aspect of being introverted is that the person becomes very aware of aches and pains in the body. And sometimes, again, that will be the core symptom of that person's condition. Now, because the thinking wheel is going more slowly, the person can't maybe string their words together as readily. The concentration is impaired because the slowed up wheel is no longer mopping up information coming from the person's environment. Another aspect of not being able to visualize a future is this. The person ends up with fatigue. Energy is a figment of our imagination, literally. If we see something in the future that we want to do, a task we have to do, a phone call, a holiday, whatever it may be, we're drawn to that, and that actually creates energy. So energy comes from what's on our mind. That's why, for example, people have more energy on Fridays than they do on Mondays. It should be the other way around if it was just purely fatigue. But people are more energetic on a Friday simply because more often than not they can't wait for the weekend. Now, the opposite happens in elation. Here, in elation or a manic state or a hypomanic state. Now, just again to point out this core aspect of the condition, mania means speeded up. That's actually the derivation from the Greek word. Mania means speeded up. Depression means slowed down. So the core old-fashioned term of manic depressive illness had some sort of meaning, but sometimes when the names change, that meaning is lost. So in this instance, the wheel is going much more quickly. Because of that, the person can't switch off their mind at night. They manage with less sleep. They have tremendous energy because they've all these attractive images in their mind as they flit from one observation in their mind to another. And from that then comes the great energy and a great sense of the future. Initially, a person's concentration when they're high is sharper than it normally would be, but as it gathers momentum, what happens is that the concentration eventually, or the spinning wheel in the brain is going so quickly, it's not able to mop up what is being said to the person, because they're jumping from one topic of or in their mind, and very often as you're looking at somebody when they're high, you can see their eyes flicker in that way as they're moving from one thought to another in their mind, and as you're talking to them, you just can't compete with that hyperactive mind. So they are the key aspects of the condition. Now, that's in a broad way sort of an explanation of what goes on. Then we've got to look at what are the sort of broader symptoms that often emerge from that. One useful way of trying to remember what the symptoms of depression and elation are is using the mnemonic festival. If you can't remember festival, maybe you can remember fest. So if you can't fest for 2 weeks, maybe it is depression. So when somebody is in a depressed state, they will first of all have a disturbance of feeling in terms of feeling low, down, depressed, and sometimes anxious or panicky. Because again, remember that when people go into a depression, very often in the early stages of a depressive relapse, it's preceded by a period of anxiousness. The person feels their energy is drained, they feel tired, flattened, or leaden. And that is often actually a much stronger symptom of depression than actually the word depression. Because oddly enough, the word depression is not a great word to describe depression, because we're inclined to think of it as a sad state. But in fact, it's a very physical state for people who experience it, because they feel extremely tired and leaden, as if they're being knocked over by a bus. It's so extreme. Many people, when they get it the first time, think they've come down with some serious illness. The person is oversleeping, napping by day, and often maybe wakening early in the morning. It's important to note that somebody who is depressed does not typically have trouble getting to sleep. It's often something that's mentioned in literature that, yes, you have trouble getting to sleep with depression. Absolutely, it's not the case. The next point is that a person's thinking is slowed down. It's slowed down, they've impaired concentration, and as I said already, a person's thinking is negative. Loss of interest is reduced. Interest in food, sex, religion, TV, or whatever the person's usual pursuits. And it's often the thing that the person values most that they miss first. The value the person puts on themselves is diminished with thoughts of reduced self-worth, and maybe at the very extreme, the person may feel they're absolutely worthless, evil, damned, wicked, and be absolutely convinced of this. In other words, it reaches what we call delusional intensity, i.e. a fixed false belief that the person is convinced there's no hope for them. Aches and pains are very characteristic during depression, not for everybody, but for many people. And as I said, for some people, they are the symptom to the fore. So it can be headache, tightness around the head, tightness in the chest, back or bowel ache. So basically the body is covered with muscle from head to toe. There's a tension in those muscles right throughout the body when somebody is depressed. And depending on the person's configuration, the way they hold their head, whether they've had an old football injury or whatever it may be, or a bit of a dodgy back, that's often where the thing will present itself. So, but many people will recognise when they're getting depressed, it's a certain group of muscles that get tense first. And then finally, not wanting to live or not wishing to live. Again, that's an extension of the bleak future that person has and a preoccupation with suicidal thoughts. So festival are the characteristic symptoms of depression that are captured in international classifications. And as I say, if you can't remember the whole mnemonic, remember FEST, feeling, energy, sleep and thinking. If a person's energy is okay, it would be hard to believe that the person is actually clinically depressed. It's such a characteristic symptom of it. Now, on the elation side, it's the complete opposite. Again, the person is feeling great. Typically, they'll say, never felt better, and particularly, the person feels free of their normal anxiousness. Their energy is boundless, and despite having little sleep. The person's sleep often is typically trouble getting to sleep, waking early in the morning, needing less sleep. And the thoughts are rapid, leading to over-talkativeness, and generally the person may complain of having a restless mind, or is as if their mind is too crowded with thoughts, or that the thoughts are racing. So now let's look at the subtypes, because when we go back to look at how you prevent relapses, we need to have some familiarity with the subtypes. Bipolar disorder is divided up into bipolar 1, bipolar 2, and bipolar 3. Now, the distinctions are quite simple. Bipolar 1 is where the person has a period of elation or mania or hypomania, well, not hypomania, followed by an episode of depression, and often a well period lasting weeks to or months to years. The high is called a manic episode, and a manic episode is basically an elated episode of a certain severity, and typically a useful thumbnail way of remembering it is that it's elation that's bad enough to warrant a hospitalisation. In other words, if a person is fairly mildly elated, a bit over-talkative, not sleeping too well, but not too intrusive, not getting into trouble at home or at work, it's reasonable to consider that as hypomania, just a lesser degree of the same condition. This is unipolar mania, and this is almost a subtype of bipolar 1. And the important point here is that the person has just simply got the episode of elation without any depressive episode. I've put it there as little or no depression. Now, in that instance, it's particularly important that the person isn't given antidepressants for that little dip in mood, which some people will complain of, other people will just call it a bout of tiredness after the depression. The next one is bipolar 2 mood disorder, is basically where the person has a mild elation followed by depression and well for months and then another episode. So it's a milder elation or a hypomania. Next we have bipolar 3, and in this instance the highs and the lows, but the highs in these instances are milder, the hypomania, and they're triggered by antidepressants, steroids, ECT, alcohol, in other words, any substance that will elevate a person's mood. So in those instances, simply taking away the stimulus, i.e. the antidepressant, or using lesser doses of it, prevents the highs continuing. And then we have the subtype called rapid cycling mood disorder. And this is where the person has 4 or more mood swing cycles in a year. And that can get so crowded, it can be, the number of episodes in the year can be such that it's almost continuous. In other words, that the person is cycling all of the time. So we come then to another variant. This is where a person has a mixed mood. The person will typically say that they feel depressed. And anybody going through a manic episode or a high episode, they will have little phases, maybe only momentary experiences of feeling depressed. They may be weepy and very distressed. But for some people, it happens right throughout the condition. And even though the person is actually in a high state, they feel as if it's depression or agitation. For some people, it's experienced primarily as anxiety, and for other people, a very frightened state, as if they're in a type of paranoid state. But when you see a person where it's just there in a momentary way, in 5 minutes' time, that same person will be joking and laughing and not being particularly bothered about this. But what we've got to remember is that this condition mimics depression, anxiety, agitation, or a paranoid state. But in fact, the core aspect of what's there, based on the level of mental activity, is a manic episode. In other words, despite the person saying they're depressed, if you look at them closely, you will see that they're quite agitated, quite talkative, have typical symptoms, and the typical symptoms are they have trouble getting to sleep, they feel worse in the evenings, there's a lot of anger and irritability, and often they will be quite weepy. Curiously enough, people who are in the depressed phase of bipolar disorder often can't cry. So it's not that you'd rely on weepiness as a very relevant sign, but certainly that triad of features, trouble getting to sleep, worse in the evenings, anger or irritability, even though the person is saying they're depressed or they're anxious or they're agitated or paranoid, it still is driven by an underlying manic episode. So what causes bipolar disorder? Well, we know from research that a mixture of genetic factors and environmental factors are relevant. I'm not going to go into this terribly much, and I just really want to convey this concept to you. On an average basis, the causes or contribution to the problem is 70% genetic and 30% environmental. But that's just an average figure. For some people, it may be the other way around. 10% genetic, 90% environmental, or 90% genetic, 10% environmental, or 50-50, or 60-40, and so on. But the average, when you look at it overall, is a contribution of 70% genetic and 30% environmental. So some people will come from a family where there's a very strong family history of bipolar disorder, and it takes little or no environmental factor to trigger the onset of the condition. On the other hand, there are other people who have a low family history of it, or almost no family history of it, other than maybe a history of depression. And it may only when that person is maybe put on a course of steroids, or they've had concussion, or some other intrusive factor that has tipped them over into a high state. The environmental influences I'm just going to go through. It's useful to think of the environmental influences as a sort of a stimulus here. And basically what it does is it shifts the mood upwards. Now, sometimes what would shift that mood upwards is just stress. So if a person is very overburdened with their work and they go up a gear to cope with it, and then there's more work and they go up another gear and then another gear, and what you will find is a lot of people just can't go up and up and up because their brain won't allow them. They just get tired, go home, throw it to one side, let tomorrow look after itself, and so on. People who are prone to highs, the stimulus of excessive work and long hours puts them up and up, and there's no limit in that sense, and that's where the phenomenon seems to be different. So with stress factors, very often work, and this is where it becomes a problem, because sometimes people will say, no, I've never had a high, and their family will never say they had a high. But it's curious how, in instances when you look at the amount of lengthy hours, hard work, an endurance situation that the person was in, maybe for 3 to 6 months, and it may even be a year before the depressive episode started, you can see that there frequently is a link there in that sense. So what are the chemical agents that can do it? Steroids, antidepressants, hormones such as progesterone, adrenaline, which you'll get in cough bottles and nose drops, and certain Parkinsonian drugs. Alcohol and street drugs will do it likewise. They shift the mood up, that's great fun, and then down afterwards. Now, that will happen with everybody, but the swing with the average person who doesn't get a full-blown high, it may be up that amount and then down that amount. It's not too disruptive. So you've got to see these things along a quantitative spectrum. It's not that people with bipolar disorder are quite distinct in that way and separate from normal. No, they're not. It's just that other people, when they're stressed or on steroids, they get maybe a bit buzzed or a bit agitated, maybe have a night or two bad sleep, but it stops at that. It doesn't go beyond that. The other environmental factors are jet travel through time zones and sometimes the change of the seasons. Another stimulus that we're becoming much more aware of is the effect of infections, or when the immune system is agitated or activated through viral illnesses, bacterial illnesses, hay fever, and there are some people that would maintain that one of the reasons that mood disturbances of a high nature happen in springtime is related to the pollen count and so on at that time of the year. Yet to be proven, but anyway. But it's certainly true, and I would have seen over the years where people, every time they get high, it co-occurs with a urinary tract infection. And sometimes simply by keeping the person on a maintenance antibiotic, it can actually prevent the recurrence of the mood disorder. So there's a very close relationship between the onset of mood changes, particularly of a high nature, and urinary and chest infections. Then obviously anything that disrupts a person's sleep at night, pain, sunburn, any ache or pain that keeps a person awake repeatedly who has a tendency to bipolar disorder will trigger the condition. As I say to some people, if you want to relapse, just stay awake. Okay. In other words, do the opposite. Get a good night's sleep. And that's where routine sleep pattern, routine mealtime and all that has a way of of solidifying the tendency towards mood disturbance. Concussion, brain insults or bangs on the head, multiple sclerosis, brain tumours. So basically any physical disorder of the brain can present as a hypomanic condition, and that's why having MRI brain scans, which are now much more readily available, they should be conducted on everybody who has bipolar disorder. And particularly if a person develops bipolar disorder and there's absolutely no family history of the condition, one has to really suspect that maybe the environmental factor is a big issue in that person's instance. So, Now, let's look at the subtypes and in terms of the treatments involved. So going back to bipolar 1 disorder, we said it's a large episode, a manic episode, followed by a depressive episode, often with periods of wellness lasting months to years. But follow-up studies have shown that those sort of conditions do recur, and often as the years go by, the interval between the recurrences gets shorter. So what are the treatments? Well, the first thing is that when we come to look at bipolar disorder in terms of medication and different skills that the person can use and therapies they can use to try and help keep their mood stable, medication is still the primary treatment preventing recurrences. Where the skills particularly come into place is helping the person to improve their quality of wellness. And we'll come to those later. Lithium is still the treatment of first choice for somebody with a straightforward bipolar 1 disorder. In 80 to 90% of instances will prevent a relapse of the manic phase. Now, sometimes that person still needs a gentle antidepressant effect from either carbamazepine, which is Tegretol, oxcarbazine, which is Trileptal, or lamotrigine, called Lamictal, or a low dose of an antidepressant. Other treatments that are used are things like Epilim, sodium valproate, Topamax or topiramate, and antipsychotic agents, which are all, in their own right, anti-manic as well. How do we treat unipolar elation? Depending on where the patients are sampled from, as many as 10% of people with bipolar disorder have a recurring unipolar elation. And you will often see that being the case, that pattern is much more common in younger people or people who develop the condition in their teens or early 20s. And often if you follow that person over years, the more typically will have depressions at a later stage in life. And the management of this is different because, as opposed to in people who have a high and a low as part of bipolar 1, in this instance now what you find is that lithium will only prevent a recurrence in about 40% of people. If you add Tegretol, carbamazepine, sodium valproate, Trileptal, or other things like that, it will probably rescue another or prevent recurrences in about another 20%. So a specific anti-manic agent such as haloperidol, olanzapine, or quetiapine, that's Serenase, Zyprexa, and Syricule, will work for some 90% of people. But frequently it takes a while to try and get on top of that problem. Because one of the problems for people who have this pattern of illness, the unipolar relation, is that they don't get a depression. Yippee, says a lot of people. But for that person then, they don't have a great motivation for getting treatment because they want to hold on to the high. People who get a belt of depression often are much more motivated in terms of getting successful stabilization of their condition. When you come to bipolar 2, this is where we have mild elations with depressions and often periods of wellness lasting weeks to months. In these instances, one of the most important things is to try and reduce the antidepressants. Because here we have a situation where the person is having quite bad depressions and they have highs, but they're not that bad. And frequently the highs are quite overlooked. Frequently the person themselves doesn't realise they get highs, and family members, when you interview them initially, will say, no, he never gets high, she never gets high. But then when you ask them to keep a log of the person's mood on a day-in, day-out basis, you get quite a different picture. You can't treat that type of history of recurring depression and pick up the highs without observing the person's mood over quite a period of time. So what do we use here? Well, first of all, as I say, is reducing the antidepressants slowly or discontinuing them if the elations keep occurring, and using what we call one of the anticonvulsant mood stabilizers. They're things like carbamazepine, oxcarbazine, sodium valproate. Many of you will know those as Tegretol, Trileptal, and Epilim, or olanzapine, quetiapine, if those don't work. So again, the key thing in this instance is deal with the elation first, get that under control, and then you come back and sort out whatever's left in terms of the depression end of it. So in managing bipolar 2 is trying to get a balance between getting the elation under control without leaving the person stuck in depression, and then you have to try and help them out of that if that's what's happening. With bipolar 3, this is where the highs are triggered by substances. You phase out the antidepressants slowly, or whatever agent is triggering the high, and you use the mood stabilizers as you did in bipolar 2. Now, rapid cycling mood disorder is typically more difficult to treat because it's almost as if it's an end state of unstable moods. So in other words, the mood is sort of up and down an awful lot. There may be almost no well periods. And did that start out as a bipolar 2, which has speeded up over the years? Did it start off as a bipolar 1 that speeded up over the years? Because the end picture often looks the same. And therefore it's not clear what's the best approach to it. So what we look at here is some sort of characteristics or triggers or things that rapid cycling bipolar disorder is associated with. And one of the things it's associated with is postnatal states. Many women who get postnatal depression may have an aspect of rapid cycling mood. It's called postnatal depression, but in fact the person's mood is up and down all the time. Why is that happening? It's thought that the hormonal effect postnatally is too much for the brain to take. In other words, having been on very large amounts of, or having had massive amounts of sex hormones floating through the brain during pregnancy, that suddenly drops postnatally and it has an effect on the brain. You will see the same in a sudden onset of menopause, and you will also see it if a woman has her ovaries removed for some surgical reasons, often a tumour. That sudden jolt in drop in sex hormones leads to an instability in the mood. Now, typically the person would say it's depression, but only when you dig into it, you actually realise that the person's mood is actually up and down. If you treat it as depression with an antidepressant, you'll worsen it. So that's why, again, being aware of the fact that there is a high there is important. Another impact here is steroids, and thyroid deficiency can be associated with it. Now, very often people who get this rapid cycling, they may have had recurring depression, maybe a depression in their teens, 10 years later maybe another episode, 5 years later another episode, and as they get closer to midlife, the pattern changes. Now, rather than just simply having depressions, they're also having periods of highs. Is it related to hormonal changes in midlife? Nobody quite knows. Is it from being on antidepressants over the years? I've seen the occasional person who's had recurring depressions throughout their life, who was never on an antidepressant, and in midlife their mood actually changed into this pattern. So the chances are it's some thing related to changes in hormones, because this would seem to be important. So very often when people get mood, bipolar disorder can start at any time post-puberty, and it's likely that the hormonal changes from puberty onwards are a factor in the establishment of the condition. But they're only triggers, they're not the cause. So how would we treat a rapid cycling mood disorder? Well, first of all, chuck the antidepressant, because it can be contributing to it. The next thing is things like anticonvulsant mood stabilizers. Again, they're Tegretol, Trileptal, sodium valproate. They work for about 50% of people. It can take a while for them to be, the level to be increased to a sufficiently therapeutic dose, and it has to be observed over a number of months before you can see an improvement. But it can be very effective. Lithium, without antidepressants, reduces mood swings in about 50% of people with rapid cycling mood disorder, and for about 30% it works. But again, each one of these trials that you have to go through with rapid cycling mood disorder takes maybe 6-9 months. So it's actually quite a consuming thing in terms of time and distress that the person often goes through before the thing is stabilised. I would often have said to people who would present for the first time with a rapid cycling mood disorder, yes, it can be treated, but it may take months to up to a couple of years, because you've often got to move from one treatment to another until you get one that is effective in the person's instance. So that's the medication end. Probably the most important thing in preventing relapses of bipolar disorder is daily rating of mood. When you go back to your clinician, therapist, doctor, whatever, for a visit, and there's an interval of weeks to months, and you're asked, how has your mood been in that interval? The report you give is largely going to be dictated by how you've been feeling in the past 3 days. It's notoriously inaccurate, and the only way to improve the accuracy is to log your mood on a daily basis. That's the first thing. The second thing about logging mood on a daily basis that I'm beginning to realise is that when people do that, when they document their thoughts and their feelings, they often become aware of feelings and thoughts that they weren't aware of. They're in their head, but they're bounding around in there, or the person is so busy with other things in life that they don't notice them. But often within that information, in terms of whether they're feeling depressed, agitated, restless, fearful, anxious, worrying, whatever it may be, any one of 30 different adjectives, and what their sleep pattern is, even if it's only fairly minor changes, it's zoning in on those and realising that they are there and taking appropriate action to deal with them. Because that's how you capture the early features of relapse when this thing is in its infancy, and it can be treated much more readily. Lifestyle issues, as I said, are extremely important, and this has got to do with the fact that our circadian rhythms in the brain control other cycle systems in the heart, in the gut, in the lungs, all over the body and other parts of the brain. So any of you that have experienced jet lag will know what that's like, or anybody who has to be up all night working when they're not used to it, and the effect that can have on you for a few days. Well, people with bipolar mood disorder are much more susceptible to the effect of these changing circadian rhythms. So trying to stabilise that is done by going to bed at a fixed time, getting up at a fixed time, having regular fixed meal times, again, within limits. But so, for example, if a person is out late for a night, they should compensate in some way the next day to try and get their cycle back in track. Exercise, again, a very simple thing, has a calming effect on the brain. it increases motivation, it increases drive and energy. If people are having difficulty rising in the morning, which is a common aspect of depression, again, by getting on the move rather than staying in bed, it improves a person's motivation. It gets the thinking process in the brain going. So by being physically active, we can activate our brain. So the simple technique is, when you wake in the morning, don't lie there thinking the thoughts that are bugging you, because they'll win. You've got to put your foot on the floor and keep going. So foot on floor, no thoughts please, move. Once you begin moving at all, going and getting washed or whatever it may be, you've won the day. If a person doesn't capture that moment, they're stuck. Now, maybe if a person isn't terribly depressed, they can manage to use CBT to muddle their way out of it. But in most instances, people actually just can't do that. And just that activation is extremely effective. Taking small steps are important, because in many ways, the small steps that we take, we tend to undervalue. And particularly when a person is depressed, they say, well, what's the point in that? The point is, very simple, it gets the brain activated. If the body is activated, the brain gets activated, and if the brain is activated, it tends to be more outward-looking, less introverted, and more positive about things. So when a person says, well, how do I start? Okay, I'm out of the bed, I'm moving, what next? What do I do next? Well, it's just a very simple term. Do the next right thing. The next right thing might be shutting the door, tying your shoelaces, having a glass of water, whatever it may be. So it's to value the small things, because each new thing you do activates you that bit further. So looking at some skills now that are emerging, yet unproven in many respects, in the management of bipolar disorder, but they all have a certain usefulness. And where they're particularly useful is in when a person is at a well state and helping them to stay in a well state. If a person's mood, and this is important, is significantly upset, many of these skills won't work. You just have to get stabilized first and then build those into your lifestyle. So, for example, if you take mindfulness, if somebody's anything more than slightly depressed, I won't even say mildly depressed, going down to slightly depressed, it's very difficult for people to actually push mindfulness into operation. Likewise, if somebody's anyway high, it's very difficult. But where it can be useful is that if a person is getting distressed by something, worried, worked up about something, and they use mindfulness, it can cool them down and take them out of that state before it moves on to elation proper or sleep disturbance. So that's where it's useful. So there are skills around learning to tolerate distress. If somebody's agitating you and bothering you, how do you begin to do that? Well, one of the things is becoming aware of the thoughts that you're having. And again, mindfulness will help you become aware of those thoughts, as will documenting your mood on a daily basis. So you have things like thought awareness, emotional awareness, validating your emotions. You know, many people get very bothered by the fact that they might have thoughts of anger or of jealousy. But acknowledging those is often the first way of beginning to take the heat out of them. Many people with bipolar disorder have difficulties in relationships, at home, at work, in their social lives, and it's often that their emotional sensitivity leaves them prone to erupting in a variety of situations. So learning how to regulate emotions and resisting the urges to engage in behaviours that will fuel those disturbed emotions, such as using alcohol, street drugs, excessive caffeine, things like that. So knowing the difference between thinking intellectually about something and how we deal with things emotionally, and trying to strike that balance through looking at things through what's called the wise mind. In other words, using our judgment rather than rushing in emotionally or being so stand back from the thing, we only deal with something at an intellectual level. So in many ways, people have difficulty within the context of bipolar disorder of accepting their lives as they are. And that's an approach to that called radical openness, or radical acceptance, is a way of helping the person to try and come to terms with things. So, for example, if a person says, my daughter has an eating disorder, I just can't cope with it, and the person is trying to control that all the time, they need to learn techniques to stand back from it and to realise that there are certain things that are beyond their control and that they need help to address this. In other words, things that are beyond us in life, we have to let go. So if a person, and again, we will find that something like 50% of people with ongoing significant mood problems of either recurring depression or bipolar disorder have alcohol problems. And it goes with the problem, as do sometimes other addictive things such as street drugs, gambling, sex or food. And again, just because a person's mood is stabilised, those things don't go away. So a person may have gotten into those as part of their mood problem, but then when their mood is stabilised, they need help to begin to deal with those particular aspects. Often these addictive behaviours are quite hidden. But sometimes one of the reasons a person doesn't recover is that these things are there in the background. We know from research that what we call comorbid conditions such as anxiety, social anxiety, panic disorder occur in up to 70% of people with bipolar disorder. So in other words, when the condition settles down, there's still this anxiety there. Now that anxiety was probably not there as part of the person's underlying personality before they became ill in the first place. It's almost as if the bipolar disorder hits on other things. And as I say, an important part of all of this is learning to sort out relationships. And we'll come back to that at a later time. So what can a person do now to try and prevent relapse? Well, the first thing is with bipolar disorder is try and acknowledge the illness. Many people are reluctant to call it an illness, call it a disorder, whatever. They find it an affront, understandably so in many ways. They would prefer it was something they didn't have. But the point is, it is there, and you need to make friends with it, get to know it, acknowledge it. It ain't going to go away. Don't reject it, or it'll steamroll you. So get to know it, and what it is, and how you can overcome it. And as I said, in the management of it, as things stand based on our research, that medication is still the primary treatment. There's no evidence that mindfulness or other types of interventions on their own will prevent a recurrence. Hopefully in time there will be evidence there to support that, but there isn't at the moment. Acknowledge the effect that bipolar disorder has on relationships. Bipolar disorder is a disturbance of emotion. When a person is high, they will often be quite agitated, overbearing, intense, and intrude on other people's space. When somebody is depressed, with the same condition, they will withdraw. So there's a constant strain on relationships with people. It's important that relatives and the individual with the condition get help for that. And one of the most useful ways of doing that is in peer support groups, such as the AWARE support groups. Because so often when people go to those meetings, they begin to realise, firstly, they're not on their own. Other people have had the same experiences, and there are other people there with the wisdom of their experience that they can learn from and not learn the hard way. In terms of preventing relapse, the next thing after learning to try and monitor your mood is how are you going to spot a relapse if it should occur? Because again, it's the early intervention is so important. When you intervene quickly, it means the person doesn't miss time away from their family, away from work, away from school, college, whatever it may be. And it doesn't have such an intrusive effect on the person's life. Now, you can do it in 3 ways. Number 1 is the ordinary signs and symptoms. That's fine for depression, because depression is a painful experience and people will know what that is, and therefore, oh, there's something wrong. If a person is pleasantly high, they may say, well, I've never felt better. I've no need for help. Why are they all thinking that there's something wrong with me? That's where the signs and symptoms become unreliable. So even if you tell somebody one of the characteristic symptoms of falling into a relapse of a high is maybe trouble getting to sleep at night. Well, is that after 5 minutes, 10 minutes, 20 minutes? Because the person might say, oh, well, I had too much coffee today, that's why I didn't sleep, or I was watching a horror movie before I went to bed, that's why I didn't sleep. So it's very easy for a person to come up with individual explanations of why the sleep disturbance isn't anything got to do with being high. So the next thing you can rely on is what people call their personal sign, or at least their family members call it their personal sign. When people are high, they will frequently do the same actions time and time again. Or it might be the tone of their voice, might be the way they hold their head, might be the colour of the pullover they wear. It might be what they're on about. In other words, investing in something or wanting to go out and dig a potato plot on 2 acres or whatever it may be. And for the next 5 years, they mightn't have the slightest interest in it, but now it's an important thing to that person. Once the family hear that, they know we're in trouble. Okay? And it may be no other sign of the elation. The most foolproof way of spotting elations early is to appoint a family member or a good friend who knows you well, that they can see if a person is slipping. Because they can tell, even over the phone, the tone of voice, the length of the phone call. If you have picked a spotter like that, it's important to pick them at a time when you're well. Not when you're high, not when you're low, but when you're well. And you say to them, I've been high, it may happen to me again. If it does, I want you to do whatever you think is appropriate. Whether that's asking me to go and see the doctor, taking away the car keys, the credit card, even getting me into hospital if you think it's so, if it's necessary. If you can trust somebody like that, you've a head start on staying out of trouble. And generally getting help for the problem at an early stage. The next thing is to arrange an emergency plan with your doctor in terms of medication adjustment. Most people that I would know who have bipolar disorder, once they're stabilised and they have an understanding of the medication, they would always have a side script or a leeway in the dose of medication that they can vary, that we will have worked out based on what works for them. And it's often maybe 10 to a 50% adjustment in one of the medications, because it only takes one of the medications to keep things on track. Know the triggers: alcohol, coffee, lifestyle changes, whatever they are, and be rigorous about them. People will say, well, look, is it okay to take drink? Yes, it's okay to take drink, but work out what it is you can take that doesn't affect your mood. That's important. Secondly, if you've worked out what that is, for heaven's sake, don't think now you can take it every day. In other words, frequently people who might say they can take 2 drinks and it doesn't affect their mood, that's fine. But if that person takes that every day and they're not used to it, it will, after even 3 days, begin to have an effect on their mood. Likewise with coffee and other things like that. So the final item then is talking over hurts. In the course of depressions or relations, people will do and say things that upset others. People at home, work, socially. Often when a person gets into those situations, when their mood settles, particularly when they come out of a high, they're often quite embarrassed about the whole thing. And they simply don't want to talk about it. It's important that if you've been in a high, that you reflect on things you've said or done. And it's important to go back to the people concerned and say, look, we need to talk about all the names I called you 2 weeks ago. Not pretty stuff, but the point is, if you don't deal with it, it gets swept under the carpet, because that person that you upset or offended maybe, they won't want to bring it up either, because they don't want to upset you. But the point is, if you don't lance that situation, it just is something that accumulates and gets swept under the carpet, and you'll find in 2 or 3 years, suddenly that person will walk out of your life. Why? Most people can't see it coming. I would often see people where you can see there's a rift happening in a relationship, there's a quietness, there's an unsaidness about what's going on, and you have to point it out to the person, look, please go and talk to your husband or wife, as the case may be, and thrash it out. Because if the person is given the opportunity to ventilate their upset about it in a genuine way, and the person listens to what's going on, number one, it protects the relationship, it allows it to heal, and furthermore, it is more likely that the person, having admitted and acknowledged publicly how they've upset the person, they're less likely to do it again in the future. So the question is, can you prevent relapses in bipolar disorder? Yes, you can. There's often, though, a long interval between the condition being diagnosed and successful prevention of it. And that's where the issue is. So that's why these personal strategies become very important, why relationships have to be protected, why early intervention is so important in terms of preventing suicide, hospitalizations and so on, or the person accumulating debt or getting into dodgy relationships or ending up with a drink or drug problem. So even if the person's mood is still swinging, if some of the social consequences of the condition can be limited, again, that's all part of preventing relapse. It takes the heat out of it, but it does take time. Yes, you can overcome bipolar disorder. It takes time, work and patience, and first of all, acknowledging the condition and getting to know it. Thank you for your attention.